The next presenter will be Ralph Hawkins, and he's going to be presenting on Lyme disease from the perspective of a general physician in active clinical practice. Ralph is the Clinical Associate Professor of Medicine at the University of Calgary South Health Campus Hospital site, where he's the lead for the Division of General Internal Medicine. Please welcome Ralph.
Thank you.
That's on for 20 minutes. At 18 minutes, it's going to go yellow.
Sounds cool. Thank you. Merci beaucoup. That's the only French you're going to hear from me, I'm afraid. I'm not bilingual functionally. It truly is a pleasure to be here to talk to you all. I'm talking from the perspective of a general physician. So I have had a past background as a family doctor. I am now a clinician in internal medicine. So I provide my comments from the perspective of the 35,000 primary care physicians and the 3,000 general internists in this country. My disclosure slide is here. I have no grants or research support. I serve on Speakers Bureau for a few of the major pharmaceutical companies, mostly in areas of metabolic syndrome, hypertension, and diabetes. The other disclosure I'd like to give is one that we're held to by the Canadian Medical Association Code of Ethics, and that is the recognition of a responsibility to give generally held opinions of the profession when interpreting scientific knowledge to the public, and when presenting an opinion that is contrary to the generally held opinion to so indicate. And most of what will follow is going to be a departure from what most of the physicians, I believe, would probably hold to. I have no disclosure of commercial support, and I really don't know what the commercial support for this meeting is. I imagine it's none, and I have no mitigating potential biases to report. I'd like to report on behalf of one of my patients. We refer to Lyme disease sufferers as patients because the word patient actually derives from the word to suffer. I think Dr. Gregson was quite eloquent last night when he talked about his experiences over 33 years with HIV patients. And it was quite palpable, the suffering as a physician that he expressed in dealing with those patients. I graduated from medical school 35 years ago. And I continue to suffer with my patients when they have setbacks and drawbacks. I'd like to report about this patient, TS. I have her permission to provide this case history. The picture that is depicted is the day that she got her tick bite in Calgary, Alberta, within the city limits. She's an athletic, healthy young mother. She did have an arthropod bite below her scapula on April 19th, 2015. She recognized the bite later in the day. After a few days, she developed a rash that was larger than a loonie, and it expanded over the course of several days. And as most young, healthy individuals, she did not seek medical attention. May 27th, about 5 weeks later, she was admitted to the hospital, our hospital in South Calgary, with persistent headache, dizziness, blurred vision. She was collapsing spontaneously and unexplainedly at home. She'd been in the hospital for 10 days before I got involved in her care in consultation. No diagnosis had been established at that time, and she had new symptoms that include generalized arthralgias, diplopia, paresthesias of her limbs, and her provincial screening for Lyme had been done and was negative. Her C6 test was reportedly negative, drawn 7 weeks after her incipient bite. The infectious diseases specialist at that time advised her that Lyme disease had been ruled out by serology, and this is the notation from the medical record. This is the two-tier testing that the Centers for Diseases Control recommend for testing for Lyme disease. And this is the methodology that's employed in the province of Alberta. The first test is a screening test, such as the C6 immunoassay. If it is positive or equivocal, you go on to have a Western blot study. But if it is negative, you are advised to consider alternate diagnoses or to have the test repeated several weeks later if your signs and symptoms persist. We talk about two-tier testing in Canada, but the 2 tiers of two-tier testing are not done on 98% of people, because the ELISA is only going to be truly positive in those who have Lyme disease, and it's going to be falsely positive in those where the test has false positivity. So most patients don't have 2 tiers of the two-tier testing. So our persistence of the terminology that we use two-tier testing in Canada is actually a falsehood. Truly, most people have 1-tier testing. Could I have slide 36, please? The C6 test is a patented test by Immunetics. This is their product monograph. If you look at the enlarged version of the product monograph, you'd be able to read all that is here. But the C6 test's intended use, as licensed in Canada, advises that negative results, either first or second step, should not be used to exclude Lyme disease. So we are using the C6 test as part of two-tier testing explicitly against the licensed intended use of the product. The intended licensed use of the product is for it to not be used in this fashion. I neglected to mention as part of my preamble, if this sounds a bit legalistic, I do have a Master's of Law degree from Newcastle, and much of my thinking regarding Lyme disease is actually colored by my experience with my medical law degree. The two-tier testing that we're talking about as an acute study, only has about 45% sensitivity. If we employed acute and convalescent serology rather than this acute testing, we would see an improvement in the ability to identify acute Lyme disease in the 75 to 80% range. I know that Dr. Datweiler is on record from years ago as recommending acute and convalescent serology rather than relying upon the two-tier testing. And I think that that is an appropriate approach that we should perhaps be teaching primary clinicians. Sir William Osler, the father of modern medicine. William Osler was a professor at Johns Hopkins University in 1912 when my grandfather graduated from Johns Hopkins. So my grandfather was actually a student of William Osler's. He's famously known to say, listen to your patient, he's telling you the diagnosis. Well, the stories that we heard last night reflect dismissiveness, clinical arrogance, condescending patient contact, prejudicial treatment, humiliation. Just about brought me to tears then, it's just about bringing me to tears now. You know, the Canadian Medical Association Code of Ethics is something that we should adhere to as physicians. So there are fundamental requirements that the Canadian Code of Ethics oblige us to uphold. I'm going to read to you the first 3 fundamental responsibilities. This is number 1, 2, and 3 in our Code of Ethics. Number 1, consider first the well-being of your patient. Number 2, practice the profession of medicine in a manner that treats the patient with dignity and as a person worthy of respect. Number 3, provide for appropriate care for your patient, even when cure is no longer possible, including physical comfort and spiritual and psychosocial support. The stories last night did not reflect that. We as a medical community in Canada are failing our patients, and we as senior physicians are teaching our junior physicians this bad behavior. We need to not teach our junior trainees this dismissive, disrespectful behavior, please. Dr. Gregson suggested that we need science and more science. I would add to that, we also need care and compassion and clinical competence, please. So my patient TS was started on oral doxycycline, and her serology was sent to the State University of New York lab at her expense. Her C6 was negative, just as it was in Canada, but she had interesting findings on her blots. And her blots showed that she had a positive IgM, drawn 7 weeks after her bite. She had 10 positive bands on her IgM. She had 5 positive bands on her IgG, but this was declared indeterminate because only 4 of those 5 bands were bands that have been arbitrarily defined as being CDC positive bands. Faced with this information, our local infectious disease specialist said, "This is all false positive because the C6 is negative." The rationale that was employed to say that Lyme disease had been ruled out. Alberta is non-endemic. We don't have ticks that carry Borrelia in Alberta. That's false. The patient did not specifically identify a tick as the source of the bite. Well, that's common in Lyme disease sufferers. A tick, or observing a tick biting you, is only seen in perhaps 20 to 40, maybe 50% of cases. The rash described was not typical for erythema migrans. We didn't show it to a doctor. We didn't have a picture of it, so it was dismissed. The duration of the tick bite was too short to transmit the disease. I hope to be able to address that at some point in the discussions, because this idea that a tick needs to be attached for 36 hours or 48 hours is, in my view, foolishness. Thank you very much. My specialist in my hospital advised that because the C6 was negative, we should never have sent those studies for Western blot study. The reported IgM was positive, but because it was more than 4 weeks after the bite, it should be considered negative and not positive. The IgG Western blot was negative according to criteria developed by the CDC in 1995. I'd love to talk about those criteria. I've got 7 minutes left. We'll do that some other time. And system persistence following her antibiotics means that she probably didn't really have acute Lyme disease. She had something else. She probably has chronic fatigue syndrome, or maybe she's depressed or what have you. Could I have slide 44, please? In my view, we're not being helped by the National Laboratory either. The National Laboratory published their guidelines for the Canadian Public Health Laboratory Network. And here is how the Canadian laboratory responds to Western blot testing. A Western blot that fails to meet all of the criteria set out by the CDC working group would be reported as negative. So if my patient's serology had gotten to the national lab, because it was 4 and not 5 bands positive, according to this, it would be reported as negative. The national lab specifically does not report band patterns. And this is one of the reasons why we can't rely on a negative report from the national lab. We have to send the specimens somewhere where we get a band pattern reported to us, always at patient expense. If the National Lab of Canada would simply report band patterns to us, I would be able to abandon that clinical practice. And when the serologic testing requested for Lyme, the screening test positive, subsequent Western blotting is negative, they will simply report that it is negative. Again, when serologic testing is requested for Lyme and when the initial screening test is positive and the subsequent Western blot confirmatory test is negative, specimens should be reported as negative. Western blots lose sensitivity over time. These tables come from the product monographs of the IgGM blot kits and the IgG blot kit, and it identifies the failure of the IgM Western blot serology after the first 2 or 3 months. And it reports the failure of sensitivity of the IgG after about the first year, with an 81% sensitivity for the IgM after the passage of the first year, and the upper limit of the confidence limit being in the 90% range. So it is mathematically and scientifically impossible for the two-tier test to have a sensitivity higher than 90% in people who've been sick longer than a year. I think, based on my legal background, I think we need to look at the evidence of the presence of Lyme disease with a different lens. And the different lens I think we need to use is a lens that I take again from the law. We need to look at cases where Lyme disease is definite. These are the criteria that have been already established by the CDC, where there is clarity that you have a positive two-tier, or you've got a positive culture, or where your spirochetes are observed by dark field microscopy, or where you have a single-tier IgG Western blot study that meets all of the criteria, definite Lyme disease. But I think we need to expand that. And patients like mine who doesn't meet the CDC criteria, but I think by every lens that you can apply has probable Lyme disease, should have the diagnosis of probable Lyme disease. And I think we should expand that further and say that if people have a plausible case for Lyme disease, that should be considered as well. I take that from the Canadian rules of law. These are the rules for evidence in the Canadian court system. The preponderance of evidence, the likelihood that more likely than not that a person has Lyme disease. We take an example that's in common circumstances right now. O.J. Simpson. O.J. Simpson was found not guilty by a court, but I think the court of public opinion has identified that he is probably guilty of murder. And that is the type of tests that are used in courts of law. He was guilty when there was a civil trial based on preponderance of evidence. We can talk about the different types of evidence during the question and answer period. So what should a Canadian framework include? I think we need to include different definitions for epidemiologic surveillance and actual clinical treatment of patients who suffer the effects of Lyme disease. We need support for research. We need the government to fund basic research, scientific research, bench research, clinical research. We need to help patients. We need to maintain an open dialogue. I have great respect for people who have different opinions on this than I do, and I acknowledge that my opinions are in the minority, but I think we need to have a dialogue about the ideas in order to move forward. My patient is doing well. She was treated aggressively for Lyme disease because I believe she had probable Lyme disease for reasons that I talked about. She is doing well. I hope that we can afford this type of treatment to more Canadians, and thank you for listening. Thank you. And thank you to the girls at the back for flipping the slides around.
Thank you, Ralph.